Can I ask the other speakers to come and join Mitch up here, and if Mitch grabs a seat, and we'll go through. While they're getting ready, there's been a few comments coming through about where's the information around the Sprint audit. So there is information on the website, and I know that the groups that have done the audits are either submitting paper for publication or in the process of developing that. So once those are accepted and published, then that will go up on the website as well. So that will be a good place to keep an eye on. So I know some of you have got cold feet and cold hands. I have to go and get my jacket. We are trying to work on the aircon. If we get really desperate, we'll get one of the physios to lead us on some kind of exercises. So we've got plenty of questions. We will have a go at getting through a number of these. So, Jack, I wanted to start with you. We've heard about how useful data is, and we've also heard about the importance of standards, and we've seen in Rebecca's presentation the standards put up. Nutrition wasn't on there. Would you like to make some comments about that?
Okay, and I was horrified to see on my slides that I didn't actually acknowledge the rest of the team that was involved in the hip fracture registry. So I will be, when I learn Twitter later, I will work out how to tweet an apology to all of them and publicly to hashtag FFN and everybody else in between. And also, if you want to find the data, I can just address that a bit more as well, is if we might actually get someone to send out a tweet, but if you don't tweet it, if you just Google ANZ HFR and sprints, you will see the sprint audits and the recommendations out of those as well. So if you just Google ANZ HFR and sprints, that would be great. Now, onto standards. So the question is around clinical standards, and it would be absolutely fair to say that data does drive change. And if you look at any implementation science model, any knowledge translation science model, any complexity science, whatever type of change model you like, even the PDSA cycles, they all need data. And the best way to get data is to actually have standards that require that data to be collected. I'll just say that I've been pushing very hard for a while, and there is very firm data to show that malnutrition is actually more harmful than just about any other indicator that you could collect in terms of influencing outcomes for patients who have broken their hip. And there is also solid evidence for a number of different interventions that could be used. And it would also be fair to say that those who are looking at the review of the standards are aware of that information. So I'll just leave it at that, and I look forward to seeing what happens next. If any of you are in any positions, and if you agree with what I've just said, if there is an opportunity for consultation, if the standards come out for consultation at some stage, feel free to feed that back. Does that answer your question all right?
Thanks, Jack. Can I also ask, there have been a few questions about this around the focus of assessment versus treating. So we can assess till we're blue in the face, but really what we need to go on is get, nutrition into people. And as you know, a number of centres have got, blanket, HIP diet, for example. So where those sites that, are struggling with this, where do you think we should be putting our efforts? So trying to get some screening done or actually feeding people?
Yeah, look, so most nutrition care models globally go through kind of screening, assessment, diagnosis, intervention, monitoring and evaluation type processes. Screening, you've heard what I think about screening. In hip fracture at least, every hip fracture patient is at risk. In terms of assessment, they are actually a very tricky patient group to get a clear diagnosis of malnutrition, especially in those who are both overweight or obese and malnourished. And also getting the resources in some settings who can make those assessments appropriate is important to consider. So in hip fracture, I usually turn around the international order a little bit and do intervention first, because we know that the vast majority of inpatients with hip fracture get nowhere near their protein and energy intakes. So why would you wait for a dietitian to come along and do something that any member of the team, and especially the medical doctor who first admits them, cannot begin that process? So in terms of the interventions, different models use different things, but basically there's interventions around improving the food and fluid intake for patients. Then there's educational measures, and then there's coordinated care measures. Now, I know I spoke a little bit about supplements earlier, and there's questions about that, but it's no use giving someone a supplement if they don't know that they're malnourished or at risk of malnutrition. How can you make somebody take medication or food as a medicine, in this case nutritional supplements, if they don't actually know they have a disease that's one of them, or condition if you want to call it that, that's very harmful? So you can't look at these in isolation. You actually have to look at the educational processes. You have to look at, in terms of the intervention, yes, there are many different ways we can include food and fluids. You also have to look behind that about, do people actually care about nutrition, and so are you measuring it? So that there's lots of different interventions that can be used. But in answer to your question about, you know, the resourcing of it, some work we've done more generally in older people with malnutrition, not just those with hip fracture, in Queensland, across Queensland hospitals, has shown that 3 in 4 older adults who are malnourished don't actually need care delivered by a dietitian. That care can be delivered by interdisciplinary team members with just a little bit of training and a good attitude. So I think we actually need to get much better at our admitting registrars. Why can't our admitting registrars do a nutrition assessment that only takes 2 minutes? Give the patient the diagnosis. Make sure the nursing staff can make sure they're on appropriate high protein, high energy diet. I'm not going to go through all the details because you need to look at your own local data. And the most important thing we can measure is patient-reported experiences. And if we do that right, which is what we've done in Simple, we've actually mapped them to the care processes that we think people should be getting. And then we ask them, has somebody told you you're malnourished, for example? Has somebody spoken to you about what you're going to do when you go home? Has somebody told you why you're supposed to be drinking that drink that you've told me you don't like and you want to get it changed to chocolate? All of these different things can be dealt with. Sorry.
Right. Thank you, Jack. You can sense the passion coming out of Jack, can't you? So actually, well, and I mean, Anita and Karen, I was going to come to you because clearly, the nurses, are a really key part of getting people, watered and fed. So over to you.
What I was about to comment was sometimes it's actually about exploring the processes of getting the supplements on the ward and who you have to go through to make that happen. And if anyone's got the answer to that, I'd love to know it as well, because sometimes it is quite frustrating, whether it's via a speech path or it's via a dietitian or, I could prescribe it as a nurse practitioner or something like that. So sometimes it's actually getting back to those processes.
The best way to fix that would be to have it in the clinical standards.
Or also to have it on the ward, and so that a nurse can go to the fridge and actually get it, and you do that education with the patient, with the carer at the bedside.
In New Zealand, there are many hospitals that cannot get access to supplements because of budgetary reasons, and that's why it needs to be on the standards. It's fascinating.
Yeah, I think the key is keeping it simple, and we're very good at not keeping it simple. But Karen and Anita, so clearly Karen, you've highlighted the issue of, the nursing shortages, and we can think of lots of, reasons why we need plenty of nurses. But have you, and I'm sure you are, and we'll be interested to hear, strategies to attract people either into nursing or back to nursing? And are there ways that, a registry and a network like this can help support that process?
I think that it's a complex matter, but I think we need to concentrate as much on retention as on recruitment. There are big drives. I don't want to be political at all, but we've obviously got a bit of an unstable government at the moment in the UK, and one of the comments this weekend are they won't be paid anymore, but we can get anyone from overseas. That's not exactly encouraging retention of nurses. I think retention is the issue. The average age of a nurse in the UK is 52. It's a little bit better in Australia. It's in the mid-40s as it is in America as well. And so those people are leaving. So we do need to concentrate on actually recruiting people who want to stay in the profession. So making sure that they're coming in with their eyes open and making it an attractive place to be.
I would also say it's about recruiting into nursing high quality nurses as well. And I sort of garbled at the end of the my talk, but and also picking up on what Karen said about politics. I mean, in this state, they're in sort of a electioneering mode, and there's certainly been an announcement for nursing training to be subsidised here. And again, that does sort of raise that issue about poaching nurses from other states or other countries or whatever. And I did sort of hint at the end of my talk about we're just negotiating a enterprise agreement, and there is some payments in there to try and retain nurses because nurses are fatigued, and there is a lot of talk about exit plans out of nursing. So it's fraught and it's complex. Victoria have gone down the path of making undergraduate training attractive. In South Australia, we're looking at the other end of the spectrum, so guaranteeing programs at the end of the degree, so guaranteed a position in a graduate nurse program for all nurses who come out of nursing. So it is frustrating. What's also impacted on our numbers has been the number of nurses that move to COVID testing stations, move to the Department of Nursing, overseeing Medi hotels. So those nurses are now starting to drift back, and there has been a huge recruiting drive of nursing assistants in where I work, but it's sort of needing to be addressed from multiple angles. I don't know what the answer is.
And I guess some of it is about having the right person doing the right thing at the right time. So going back to what Jack was saying, is it's making sure that the registered nurses are doing jobs that registered nurses need to do, and actually the support staff, and whether that be an integrated support worker with therapists, we have nutritional assistants on wards, making sure that the right people are doing the right thing.
So that you've kind of stolen my next question out from under me, but I'd be interested in hearing from the rest of the panel, because clearly, even if we can retain and attract some more nurses, the ongoing demand, it's still not going to be a large enough workforce. And so thinking about assistance and people who can rather than just doing the helping walking, just helping with the feeding, can do a range of those. And there's certainly in New Zealand a growing look at employing, non-trained people. They are called kaiwhinas in New Zealand. But yeah, do each of you have a thought about that role?
Yeah, I've got a little bit of a thought about that, because we, the Department of Health and Human Services, I think it's called, in Victoria, did a little bit of work on developing a framework. This was specific to allied health assistants, but a framework around delegation and supervision of tasks to allied health assistants. And so that framework's still sort of up on their website and available for clinicians to use. And I think probably is a good starting point to think about that for potentially other professional groups outside of allied health, but we expanded it to delegation and supervision in the NDIS as well. So there's ways of doing delegation and supervision of tasks to I guess people not registered through AHPRA, which you can build frameworks around that mean that you've sort of got all the safeguards in place and making sure that you've got that role delineation.
So for those interested in Google, if you just look at Alita Rushton, A-L-I-T-A Rushton, she's a nutrition assistant that's worked in our hospital who's just completed a Masters of Philosophy looking at delegated models of nutrition care and barriers and enablers to that. And there's full publications that she's put out in the last year or so that very much look to answering that question. As health professionals, there's some very interesting barriers as to why we sometimes hold on to things that don't require our level of skill, and that means that we don't get to do the things that we are very skilled at doing. And the worst thing we can do is shovel work onto other people that actually doesn't require their skill either. So, like, dietitians shouldn't be just throwing work onto nursing staff or vice versa, but we actually need to make sure everybody's working to full scope. And wherever possible, if you can have one person delivering multi-components of care, i.e. probably at least interdisciplinary or transdisciplinary, that's usually better for patient experiences than having like 4 or 5 different people duplicating a lot of care. So we need to get so much better in that space, and we could become so much more efficient and deliver better patient experiences.
I'll reserve comment on a multidisciplinary worker, but just to say in my workplace we have AHAs in dietetics doing the initial screening, then that's followed up by a comprehensive assessment by a dietitian. We also have physio assistants, AHAs as well, who either assist the physio with that mobility or then returns to do bed-based exercises or other, you know, in some instances the hip fracture patients are being seen twice a day. So I think we could certainly explore the AHAs further.
Yeah, and I think providing, you know, kind of real clear career pathway and making it, you know, for people leaving school, this is an opportunity, something I could do.
So, one of the advances in the UK has been for a role called nursing associates, who have gone through an apprenticeship. So they've arrived on the ward as support workers, they go through a training programme, they're described as nursing associates. They can do everything apart from giving intravenous drugs and checking control drugs, and that programme lasts for about 3 years. So there is some career development there for those people. I think one of the big successes has been, it's not been in acute hospitals, but in the community settings, have been rehab support workers who are focusing on rehabilitation but on nursing activities as well. And I think that those sort of roles in an acute hospital would be really good. I mean, I'm ashamed to sit here and see the facts, which I know to be the truth, that you're having 2 hours of physiotherapy in 1 week, in the first week following a hip fracture. And, you know, if you could actually supplement that with people who've got the necessary knowledge and skills from the therapy team, who may be part of the nursing team and nursing activity, that are going on 24 hours a day, which would, you know, how easy is it for a nurse to push a patient to the bathroom rather than stopping and walking that patient? You know, we talk about being short-staffed, and some of it is about organisation, some of it's about time. But actually looking at providing care in different ways is going to be essential to moving forward on all levels of practice.
I'm going to move on to you, Mitch. It's a bit of a shame that you didn't get any much data from the audit about reasons people aren't able to sort of move on day one. But do you have thoughts about why there's such variation around if people are able to get up, sit, stand, move?
Yeah, variation between sites or variation between patients?
Between sites. So some sites seem to be able to get their patients up out of bed for most of their patients, others aren't. So not quite sure where the answer lies.
It's a good question. I think we could almost put that to the audience of everyone who's in the room. Where does it happen well? Where does it? Where do people struggle? You know, I think personally, I think it's hard to work out because we don't have those reasons why. I was really hoping with the audit that we'd get a nice pinpoint of, you know, it's because of pain, it's because of delirium, it's because of X, Y, Z, and unfortunately we couldn't get that. I think it's potentially related to other aspects of perioperative care apart from what the physio is doing, because I think in my experience, every hospital I've gone to, the physios are pretty stubborn about trying to get people up on their feet. And so I think if people aren't getting up on their feet, it's potentially because, I'd be interested in looking at those same hospitals and thinking, well, what's their time to surgery like? What sort of pain relief processes have they got in place in ED? Those kind of questions to try and figure out, are they more often malnourished and not being assessed for that and not being fed? And are those things leading up to surgery and in those first few days after surgery, are those things combined making it even more difficult to do something which is a very difficult task, and that is to wait there on a broken bone? So I think there's other processes of care before and immediately and even during surgery that probably vary between hospitals and that play a role in that patient's ability to get up on that first day. I'm actually going to be talking a little bit about that tomorrow, I think. So look forward to sharing that.
And this probably doesn't have a short answer to it, but I was dismayed, I think, as were some others, from questions around the thought that somebody wouldn't go to rehab because there were no goals. Clearly, every patient who breaks their hip has some things to work on. So I guess I'm interested in your comments on what should be happening to patients after the first few days. There's clearly a range of options.
In terms of leading up to that?
So I think in
rehab,
terms of who do you think is appropriate to go to subacute rehab?
Oh, that's
Big question.
Dicey question. I could get myself into trouble.
Okay, let me be. I guess let me ask.
I can give it a go.
Okay, go.
I think it's actually a really difficult question that we all need to ask ourselves around, and it was mentioned in the first panel around there's one pot of resources, of money, there's X number of subacute rehab beds floating around, and how do we most equitably and for the best outcomes distribute that resource? And I think people, in conditions of pressure where there's not many beds available, they're probably going to prioritise that 50-year-old stroke patient over the 90-year-old person who's had a hip fracture who previously lived in a residential aged care facility. That's not a perfect world. In a perfect world, everyone would have the opportunity for subacute rehab after the acute period of time, but I think that's just how people are sort of pragmatically dealing with that constraint. I think that's it. Yeah, it's a question that we need to ask around, are there different facilities as well where they're having to, the ones that are having those criteria, why have they had to make that criteria? Is it because they're under-resourced compared to the hospitals that don't have that criteria, where more people might have that opportunity? So, it might be an issue as well of how we're distributing resources between hospitals, between LHDs, between geographical regions as well. So that's my way of dodging a question to not say I think people with dementia should or shouldn't have the opportunity for rehab.
I think that's well answered. So look, that's the end of our session. I think we could go on for some time, but I'm getting hungry. I don't know about the rest of you. So can we all thank our panel?